Hi, I'm Sunil V, interventional cardiologist at Duke University Health System. I'm really pleased to be part of SIF Virtual 2020 and really appreciate Dave Ryzik's invitation to give you this presentation on my viewpoint as an editor-in-chief, as well as a clinical investigator in challenges in executing and publishing cardiogenic shock trials. These are my disclosures. I have institutional research funding from Bayer, Svelte Incorporated, Shockwave Medical. I also receive personal fees for my position as editor-in-chief for Circulation Cardiovascular Interventions, which is the subspecialty journal of the Circulation family of journals by the AHA. So I think as we start thinking about cardiogenic shock trials, it's important to keep in mind the hierarchy of evidence. And this really applies regardless of what specialty you're in. It is particularly important for interventional cardiology because as a procedural field, we oftentimes will implement strategies in our day-to-day practice that are not necessarily easily lent to testing in a randomized clinical trial. So for example, a specific technique that may be related to delivery of a stent in a tortuous vessel, really, not only is there no point in testing in a randomized trial, it may be incredibly difficult to test in a randomized trial. And that would sort of fall under the expert opinion category, which in general in the hierarchy is considered the lowest form of clinical evidence. On the other hand, mechanistic studies, which are the next level, are also important for us to understand because they lay the foundation for the development of new strategies, new devices, and new drugs. We get a lot of information from case reports and case studies because, again, as a procedural specialty, the individual variation in the patients that we see has an important impact on procedural success, treatment strategies, and the ultimate outcome. The most important level of evidence, of course, is the randomized controlled trial. And we are lucky in cardiology, as well as in interventional cardiology, for having a plethora of randomized controlled trials that support the vast majority of what we do. So for example, transcatheter aortic valve replacement, or TAVR, has been subjected to several large randomized trials, pivotal trials showing a significant benefit of transcatheter aortic valve replacement in patients who are at prohibitive surgical risk, even compared with surgery, and even in the low risk population. And we really would not have had that level of evidence if we did not have the community commitment to doing a randomized controlled trials. Unfortunately, despite the number of randomized trials that we have, it really makes up a minority of the evidence base that we use in interventional cardiology, and quite frankly in medicine. The vast majority of evidence that we see is observational. And this is really almost for historical reasons, right? I mean, in the past, physicians would observe a patient, write down the observations, write down how the patient did, and then they would communicate that to the rest of the world. As the world has become smaller, communication has gotten faster, and of course, the development of the randomized controlled trial is probably the most significant development in the practice of medicine. But I think we can also gain important insights from cohort studies and other observational studies. Now, the challenge in the cardiogenic shock space is that there have been multiple attempts to do randomized controlled trials, specifically with mechanical support. And unfortunately, they've been very, very challenging to do. Here's a list of just some trials with the Impella device. And you can see that the patients that were required versus the patients that were actually enrolled, and the duration over which they were enrolled is quite disappointing. And many of these trials were discontinued, or if they were completed, they're relatively small trials. This is not a fault of industry. It really, I think, is a fault of the interventional community, where we have developed almost a faith-based approach to treating cardiogenic shock patients. And I don't want to fault our community completely either, because these patients are very sick. Time is of the essence, and it may be very, very challenging to try and get informed consent or even enroll a patient in a trial. And at the end of the day, we try to exercise our clinical judgment in treating the patient that's in front of us. Unfortunately, without a solid evidence base, that clinical judgment may in fact lead us in the wrong direction. So this slide really underscores, I think, the fact that we have to have a community commitment to doing randomized trials to move the field forward and actually increase the amount of evidence that we have to treat these very, very sick patients. Here are some of the ongoing randomized controlled trials and the ones that have been successfully completed. It really is a very, very active space right now. There's a tremendous amount of interest in cardiogenic shock. and how to treat these patients. I think that the development of the SCAI shock classification, for example, has created a common lexicon that investigators and clinical and clinicians can use so that we're all talking about the same patients. Certainly the SCAI classification has been validated in retrospective data sets where there is an association between increasing SCAI stage and increased mortality, both in hospital as well as longer term. But I think the utility of the SCAI shock classification for randomized clinical trials is really so that we can have a more homogeneous group of patients. And because that same terminology is being used in the clinical setting, potentially a more generalizable set of randomized trials where clinicians can actually implement those strategies if they're beneficial by using the SCAI stage when they're treating patients. There are several ongoing trials, as you can see as well, and hopefully these will give us more insights. I think one of the things that I hope that you've noticed is that many of these trials are actually quite small. Some of this may be because they're mechanistic studies and use a surrogate endpoint, not a clinical endpoint. Some of this may be because the actual sample size calculation resulted in a small sample size because the outcomes are, the rate of the endpoint is just so high, and any potential intervention would have such a dramatic benefit that the sample size can remain small. But again, this is not like the large ACS trials where we're talking about 18,000 patients or 10,000 patients. These are generally less than 1,000 patients, and folks who have done randomized trials in this space will tell you that even trying to get these modest sample size requires a tremendous amount of commitment on the part of the principal investigator, the steering committee, as well as the site investigators. So what are the impediments for doing trials in shock patients? Well, as I mentioned earlier, oftentimes there's a lack of equipoise. So as we train to take care of these patients in cardiogenic shock, we all have our own treatment biases. We may be influenced by the patient that we saw last week or yesterday with shock, where we did something that may have made the patient better or worse. And so those practice patterns can certainly influence our lack of equipoise. There also may be a lack of equipoise specifically in the device space, because particularly for devices that provide a tremendous amount of hemodynamic support, when you're faced with a patient who's dying in front of you, you feel like you need to do something, and putting in this device may feel like the last resort. Despite the fact that there's a tremendous amount of activity in the space, it's a relatively rare condition, right? I mean, if you look at the vast majority of patients with ST segment elevation MI, or those who are undergoing coronary stenting, the vast majority don't develop cardiogenic shock. And because it's a rare condition, it can be difficult to enroll in a trial. These aren't patients that are coming in, at a rate of 10 per day. And so trial fatigue can set in for some of these sites. There's obviously a high risk for acute deterioration in these patients. So a patient who comes in one SCAI stage may deteriorate very quickly. And that becomes relevant when you're talking about inclusion-exclusion criteria. So when you first see the patient, you may say, this is a perfect candidate because of the SCAI stage that they're in for a randomized trial that has that particular stage as an inclusion criterion. However, as they deteriorate, they may no longer be a candidate for that trial. And so timing of enrolling that patient is important so that you can actually make sure that the deterioration can be attributed to the intervention, not just sort of clinical deterioration. I think another challenge in this space is informed consent, because these patients are very sick. Sometimes they may be intubated. They may have received several sedating medications. And does the patient really have the mental capacity to be truly informed when they give consent? A lot of the cardiogenic or cardiac arrest trials have gotten around this by getting community consent or what's called broad consent. But informed consent is a major issue for cardiogenic shock trials. And again, it requires a tremendous amount of commitment on the part of the sites so that they can get consent from surrogates or family members. And again, of course, the sites have to have an ethics board or an IRB that allows that kind of consent. As I mentioned, these patients have a dynamic clinical status. They may go from being at very, very high risk. So for example, a patient with an anterior ST elevation MI with a tremendous amount of myocardium at risk coming in hypotensive, you open the artery, you get perfusion, all of a sudden the pressure comes up and they're no longer in shock. So in that case, that patient's outcome may be very good. And they may not necessarily be someone that you would randomize, or maybe glean a benefit from some kind of intervention that may have some associated risk with it. And then, of course, funding is very, very challenging. I mean, and this probably applies to all kinds of research. Trying to get funding to do these trials that may takes several years to enroll, is a constant challenge. On the other hand, there are some advantages to doing trials in this space. It has very high morbidity and mortality, so an intervention that's beneficial may have a large effect size and therefore a smaller sample size overall. There are many centers around the country and around the world that are very experienced with dealing with in dealing with cardiogenic shock patients. So if they have a robust research infrastructure, that may be a great site for a randomized trial. Another issue around experience is proficiency with devices. If you're going to study a device, you want to use a site that has proficiency with it, sort of knows how to troubleshoot it. And so, because of the number of centers that have a lot of experience with devices, finding sites to participate in a trial may not necessarily be as much of an issue. That's a double-edged sword, of course, because if they are very proficient with it, they may not necessarily have the equipoise to randomize. Another advantage is that there are lots of strategies available to study and compare. Quite frankly, many of the strategies that we use in cardiogenic shock patients are not evidence-based. So you can probably pick a question out of 100 to try and answer with a randomized clinical trial. But that, again, that's a caveat. You want to make sure that your question is very focused and your randomization and your treatments reflect that you're trying to answer that specific question. And again, there's a high level of interest in the interventional community right now in cardiogenic shock and in doing cardiogenic shock trials. But the reality is it's supposed to be hard, right? I mean, if it was easy, everyone would do it and we already would have all the answers. The reality is it's not easy to do. It's actually very challenging to do. And that's why our community has to be committed to try and getting more data in the cardiogenic shock space. Now, I'm going to change hats here from being a clinical investigator to being an editor. We get a lot of publications on cardiogenic shock. As I mentioned, this is a very, very popular topic area. But these are extremely challenging to review. Like I said, we get a tremendous number of them. And some of the reasons that they're challenging to review is that they lack novelty. A lot of the databases that people are using may have just mortality as an endpoint. They may not necessarily have specific metabolic parameters or hemodynamic parameters. And so, if we were to get a publication that said that cardiogenic shock is associated with an increased risk of mortality versus not having cardiogenic shock, well, that's not really a novel finding. And so those kinds of papers generally will not get published into higher tier journals. Most are observational. Right? I mean, as I mentioned, there are lots of ongoing randomized trials, but the vast majority of what we get at the journal are observational studies. And oftentimes they lack a contemporary control group. And this is incredibly important. Historical controls have their place in observational research, but they're certainly not as robust as a contemporaneous control group. So you always have to be a little bit careful when you're comparing a certain treatment strategy or a series of treatment strategies against a historical control, because lots of things change during that history. It's not just the treatment of cardiogenic shock, it's how we do procedures, it's the kind of stents that we use, it's the pharmacology. It may even be things that are not measured, like what kind of support staff the hospital has, whether the ICU nurses are trained in hemodynamic support. All that changes over time, and it's almost impossible to control for all that. And that leads me to probably the most important limitation of many of these observational studies, which is the unmeasured confounders. We don't know what we don't measure, right? So a lot of those things may in fact influence the associations that are found in specific studies that are using databases that are not necessarily designed to look at cardiogenic shock. One of the other issues, and this is not just about cardiogenic shock, but in observational research in general, is that oftentimes we tend to overestimate the importance of our own work. So a lot of times we will get papers where the conclusions way overstate their findings. It's fine to say that, an association is found and this calls for more research, or it calls for circumspection when you're using a certain treatment strategy, or maybe we need more data to figure out who the right patients are. But if you say something like, we need to stop using this device, or this device should be used in everybody, that's really an overstatement of what observational studies really can and cannot show. Another big issue, and this is sort of manuscript writing 101, is the use of causality language in observational data. So if you are looking at observational data, in other words, non-randomized data, and you are showing, let's say, an association between the use of early revascularization in shock and reduced hospital stay, the way to phrase those findings, if the patients were not randomized to early versus later revascularization, is to say there's an association between early revascularization and decreased length of stay. And the reason you have to say it that way is that there may be other things that you're not measuring that are influencing that particular outcome. What you should not say is that early revascularization leads to a shorter length of stay. Because again, that's causality language, and you're not looking at causality. Remember, correlation is not causation. And again, it's important to be circumspect about the findings in observational data. The other thing that goes hand in hand with that is to make sweeping statements about the impact of the findings. So, you know, if you're looking at observational data and you say that in the absence, let's say there's no randomized trial, and you are looking at the association between chloride level and outcomes in cardiogenic shock, and you find that in your database, there's an association between elevated chloride and reduced mortality in shock. You know, first of all, it's hard to figure out exactly what the mechanistic reason for that is, but putting that aside, if you have a conclusion that says that these data strongly recommend that all patients with shock should have their chloride levels elevated, well, come on. I mean, that's a sweeping statement about the impact of the findings, and the reality is that's not exactly what your study is showing. And finally, this is a particular pet peeve of editors, which is to use industry marketing terms. So terms like unmet need, those are industry marketing terms. Unmet need is not something that you generally see in scientific publications. There are other commercial or marketing terms for drugs and devices that often find their way into scientific manuscripts. And I would highly recommend that you avoid using those terms, because what that tells the editor is that you have been, your impartiality for the science has been compromised. So in summary, you know, if I were to tell you again my clinical trialist and editor view on cardiogenic shock, you know, cardiogenic shock is a highly morbid and mortal condition, and we do have to find better ways to treat it and improve the outcomes. Unfortunately, what we have now is a lot of observational data, but they suffer from confounding. And it's important to be very, very careful about how those findings are phrased and what that means for clinical practice. Trials, we absolutely have to have clinical trials. I mean, that's how we should guide practice, but they're very challenging to do. So we need to be a little bit more creative about having pragmatic designs and novel approaches to doing randomized trials. Smart trials, adaptive trials, those kinds of cluster-based randomized trials, those kinds of things are really important to start thinking about in the cardiogenic shock space. From my perspective as an editor, we've seen a dramatic increase in submissions related to cardiogenic shock. But unfortunately, a lot of them don't have novelty, they have too much confounding, and they really, really overstate the results. So I guess my final statement with respect to this particular topic is that because cardiogenic shock is a highly mortal and morbid condition, we really need more high quality data. And I would challenge all of us to participate in randomized trials so that we can continue to move the field forward. Thanks very much.